Good evening, everybody. My name is Casey Hine, and tonight we're going to be talking about how essential our role is in this war on diabetes. I believe oral health care providers have a profound place in this war. And here's some of my ideas tonight about this. I want to start by thanking Sunstar for their sponsorship of this program. And a special call out to Tom and Ann. Thank you. And in terms of conflict of interest, I do want to report that I am a member of the advisory board of Sunstar America, and I receive honorarium for research, speaking, and or writing from Sunstar America, Florida Probe, Perio Protect, and Colgate. In 2003, a physician by the name of Berwick wrote something that I think is extremely profound, and especially so today. And this was almost 20 years ago. He wrote, "Healthcare is among the best endowed of all industries in the richness of its science base. Yet an enormous amount of that scientific knowledge remains unused." And I would be hard put to think of an area of science that this more aptly fits than periodontal systemic medicine. And diabetes, and has this body of evidence we have on the interrelationship between diabetes and periodontitis is, excuse me, it's not a new body of knowledge. It has been around for almost 30 years. Actually, I think it's been a little bit longer than that at this point. And yet, when I talk to dentists and dental hygienists across the country, what I find is that still we are hesitant to implement this science base. And so tonight, my goal is to present something that's compelling enough to you and perhaps exciting enough to kind of move the needle on this with diabetes, with our patients with diabetes. So I have spent the last 10 years of my, actually, let me say that over again. I have spent the last almost 20 years of my life now talking about how important it is to teach what we call non-dental healthcare providers about the significance of oral health. That was one of my primary responsibilities as a faculty member at the University of Manitoba. And I actually spearheaded and managed the first professional journal in this area of implementing oral systemic science and collaborating interprofessionally with the medical community. So I've done a whole lot of work in this area and written a curriculum, et cetera, et cetera. But I tell you this simply because what I have seen, what I have experienced is that medicine and nursing and pharmacy, for that matter, has truly gotten on board. They are doing a significant amount of things to incorporate oral health into their everyday care of patients. And what I'm finding is that to truly reconnect the mouth to the rest of the body, now it's on us as oral health care providers to start looking beyond the tonsils. And this is a really good example tonight of what I'm talking about. There's other areas that we could become involved in as non-physician primary healthcare providers. But diabetes is, in my opinion, the low-hanging fruit. This is the number one area, I believe, that we can make a significant difference. So consequently, this term dental medical integration, it's really now taking off in many, many ways. In fact, I'm going to be doing a program this fall with some other speakers. They're kind of a TED Talk program. It's a major conference on dental medical integration. So this is a time that has come. And tonight, this is just an example of how we can move the needle on this. But ultimately, it's patients that have multifactorial risk that we need to be communicating and collaborating with across professional boundaries. And point of care provisions for patients has become a major impetus, so that whether that patient is entering through medicine or dentistry, the truth is, given what we know about oral systemic medicine, we share in the responsibility for patient outcomes. So when we do medical dental collaboration or dental medical collaboration, we know that this facilitates continuity of care. So it has a huge effect on fragmentation of care. And as a result, what we can expect to see are better patient outcomes and increased efficiency and eventually cost of care. So this is starting to happen throughout the country. We're really not in the early adopter stage at this point. There are a lot of practices they're taking on some of these primary care services in the dental settings. Another one is screening for cardiovascular disease, and there's quite a few others. But tonight we're going to be talking about diabetes and periodontitis. So, we can ask ourselves, is this really pushing the envelope? In other words, should we back off? This really isn't in our scope of practice. And that's simply not true, because what we know today about the oral cavity and its interrelationship with systemic health is huge, and we can't go backwards now. We have to move forward in implementing the science. And in fact, it was 1945 when Belding wrote the first article on taking blood pressure readings in the dental offices. And in 1974, almost 30 years later, that's when the American Dental Association suggested that we should start screening for hypertension in the dental office. So this is with precedent. This is definitely with precedence. So exactly how can oral health care providers contribute to the war on diabetes? Well, number one, and we're going to be talking about this shortly, it's really not a level playing field for patients with diabetes, because they have a disproportionate inflammatory response to the same amount of bacteria and other pathogens than a healthy person does. So it is a very exuberant response that they have. So as a result, it's more important than ever for us to empower our patients who have diabetes to maintain good oral hygiene and to make it easy for them. We need to help patients with diabetes understand how untreated or unstable periodontitis may undermine attempts to sustain glycemic control. And as you'll see, there are a lot of people who have a major difficulty in managing their sugar. Another way we can contribute is to customize treatment that addresses the unique needs of patients with diabetes. And there are quite a few of those that we need to take into consideration. Another way we can become involved is to screen patients for diabetes and pre-diabetes. And notice I did not say diagnose. This is about screening. And yes, we're going to be talking about glycemic testing, or testing for glycemic control. But this isn't about diagnosing. This is about screening and also understanding where patients are in their glycemic control, as that has a major bearing on periodontal health. Identify patients who have diabetes that is poorly controlled, provide testing for hyperglycemia, reinforce self-care that's prescribed by patients' physicians, and collaborate with patients' treating physicians to potentially increase optimal health outcomes. And I'm sure you all are thinking of other ways that we can participate and contribute to this war on diabetes. These are only a few. So what is our catchment area? That's what I call this, right? The most recent data that looked at diabetes, its awareness, treatment, and control in adults, and this is people who are 20 and older. This was from 2013, 2016, which is the most recent data. You'll see how this kind of breaks out so that, excuse me, we have down here, almost 25% of people who have diabetes are undiagnosed, and as a result, they're not treated. And that's huge. That's huge. And many of them are in our dental practices. There's about another 45% of people who are treated but have poorly controlled diabetes, and we have a major role to play in that also. There are about 9% that are not treated. However, they are aware that they have diabetes. Only about 21% are actually treated and controlled. So if we combine these people who are not treated and controlled, it's roughly 80% of the adults in the United States, at least from this time period of 2013 to 2016, and I know that data is a little bit old. This is our catchment. These are populations where oral health care providers truly can make a big difference. So I refer to this term as the diabetes catchment in dentistry. And basically, these are the three groups that we're talking about. People with undiagnosed diabetes, they're treated, but they're uncontrolled diabetics, and others who are aware that they have diabetes, but they're not treated. So if we assume for a minute an average general dental practice consists, and we're talking about a solo practitioner, of 2,000 patients with about 1,400 adults, and we do this at 80% of that, that's over 1,000 patients who are in this catchment area. These are potentially patients that we could make a significant difference in their lives just by looking for those who are undiagnosed, those who are treated, but their diabetes is not well controlled, and those who know they have diabetes, but they're not treated. And also this 1,000 or 1,120 at-risk patients does not include young children and adolescents or people younger than 20. So, and we know that these numbers are going up. And much of that has to do with the obesity trends we see in our youth. In brief, if we look at the biological mechanisms at play here, I describe it as a spiraling interrelationship between periodontal infection and hyperglycemia. So we know for a fact that periodontal disease increases hyperglycemia. It also has an effect on hypoglycemia, but less so. So it's hyperglycemia that has the greatest effect on the periodontium. And we also know that in chronic hyperglycemia, there is increased periodontal destruction. So in periodontal disease, there's an ongoing source of the systemic challenge from gram-negative excuse me, anaerobic bacteria, their products, and locally produced inflammatory mediators, tumor necrosis factor alpha, interleukin 6, interleukin 1. These have an effect on glucose and lipid metabolism. When they're in a state of chronic hyperglycemia, where there's increased periodontal destruction, over a period of time with this sustained hyperglycemic state, that actually prevents the breakdown of bacteria in periodontal pockets. And much of this has to do with the fact that it has the periodontal pocket has become a substrate for very inflammophilic organisms. In other words, organisms that love inflammation. They thrive and multiply in that. And so this is that spiraling relationship. So let's talk for a minute about screening for asymptomatic diabetes and prediabetes. Ladies and gentlemen, this does not have to be a high-tech process. The American Diabetes Association every year publishes guidelines that include the criteria for testing for type 2 diabetes or prediabetes in people who are asymptomatic adults. They also do it for children. And again, I emphasize asymptomatic because these are people who do not have the cardinal symptoms of diabetes that such as thirst, polyuria, et cetera, et cetera. Those are very compelling signs and symptoms of diabetes. These are people who don't have that, all right? And the recommendation by the American Diabetes Association is that testing should be considered in overweight or obese people, and that means body mass index of 25 and greater. Asian Americans it's a little bit lower. It's 23 for them. These are adults. And if they have one or more of the following risk factors, they have a first-degree relative with diabetes, they're in a high-risk group, ethnicity, such as African American, Latinos, Native American, Asian Americans, and Pacific Islanders. They have a history of cardiovascular disease. They have hypertension, and that's defined as 140/90 and greater, or they're on therapy for hypertension. They have HDL cholesterol levels that are less than 35 and or a triglyceride level of greater than 250. And again, it's one or more of these risk factors, right? Women who have had polycystic ovary syndrome, people who are physically inactive, other clinical conditions such as that are associated with insulin resistance, things like severe obesity, this thing called acanthus nigricans. Actually, in insulin resistant individuals, you start to see changes in the pigmentation in tissues, the skin around the neck. And truthfully, I have seen a ton of this in my lifetime, and I always thought they were patients who did not do a good job of washing their necks, or they just got sunburned, or they were tan, or whatever. But this is a telltale sign of insulin resistance. Patients with an A1C or HbA1c of 5.7 or greater, or impaired glucose tolerance or impaired fasting glucose on previous testing should be tested yearly. Also, women who were diagnosed with gestational diabetes should have lifelong testing at least every 3 years. It's been suggested that women who have gestational diabetes, actually about 50% remain diabetic after their babies are born. So if the results are normal after testing for diabetes, You should repeat it at a minimum of 3-year intervals and consider it more frequent testing depending upon the initial results. And so again, these are ways taken together, this information. Again, it is about people who are overweight, not just obese, but overweight, and have one of these risk factors. And they also say that for all people, regardless of body mass index, testing should begin at 45. So let me ask you guys this question and think about this for a minute. About what percentage of adults in your practice might this be? And I'm guessing it's going to be way, way up there. I'm going to guess it's probably up around 85%, depending upon where you practice. And it's very, very similar for children. It's risk-based screening for type 2 diabetes, and they're very, very similar parameters here. Again, they suggest that if the screening is normal, you repeat at a minimum of 3-year intervals or more frequently if their body mass index is increasing. So again, these are factors, these are criteria that the American Dental Diabetes Association has suggested that when we screen, if there are people who positively are screen positive for risk for diabetes, that they be referred to a physician for a formal diagnosis. Here are the diagnostic criteria for diabetes and pre-diabetes. So, it depends upon which testing you want to do. It's fasting plasma glucose, oral glucose tolerance test, and HbA1c. Tonight, we're going to be talking about HbA1c. And the cut point is 6.5%. This is when we start to be concerned. And this is the cut point of a patient with diabetes. For pre-diabetes, it's 5.7 to 6.4. And it could be that changes, because every once in a while, the American Diabetes Association does change this information. This is when we identify patients that have diabetes, or we suspect have diabetes, there's a lot of questions we need to be asking them. For instance, how about experiencing hypoglycemic events? That's something we need to know, because it has a real bearing on how long we are doing a procedure, right? Ask them about their eyesight. When's the last time they had it checked? And how about your feet? What's the last time you had your HbA1c tested? And how is your diabetes being treated? Is it diet and exercise, medications? Do you take insulin? Is it a pump? Is it oral, et cetera, et cetera? So this is a questionnaire that you can access at my website that goes over those things. So tonight, we're going to be talking about how diabetes has been introduced into the relatively new classification system. It's 2017-2018 for the diagnostic framework for periodontitis, and so what I want to really target here is something called grading, which is the rate of periodontal disease progression. And this is where diabetes comes into play. So just briefly, I want to just talk about the difference here between the two classification systems. The previous one we had, which was in 1999, and they do this about every 20 years. They do a new classification system. But the previous one in 1999, it was pretty simple. to be honest, it was really was all about disease severity. That was it. And clinical attachment loss was the way they determined disease severity. So they didn't really take into consideration any systemic factors at all. Okay, so it was pretty straightforward. Well, the 2017 guidelines, this new diagnostic framework really changed that. So they came up with two parameters. One was called staging, which really is determined by looking at the severity of the disease, which was the only parameter in previous classification, but also the complexity of management. How difficult is this case going to be to manage? And the extent and distribution. Is it localized or is it throughout the mouth? And then the grading, which is the rate of disease progression, because we do know diabetes has poorly controlled diabetes especially, has an influence on the rate of progression of periodontitis. And it also has an influence on the future risk for more periodontal bone loss. And finally, the potential impact of either not treating periodontitis on diabetes or treating it. So those are considerations, things that we must think about in this new classification system. And I'm just thrilled with the new classification system because it is the first time that scientists actually incorporated the evidence into a diagnostic framework. And it's wonderful. It's not just about the mouth anymore. It's also the influence of the systemic factors. So here's Tony. And as you can see, this is a fairly extreme situation. There's a ton of calculus and inflammation, and there's lots of bleeding on probing. So you see the periodontal chart here to the left, and the little diamonds that you see in the chart are bleeding upon probing. You can see that 142 sites, or approximately 83% of his mouth, was bleeding upon probing. And you can see these other parameters. Clinical attachment loss at the site of the greatest loss was 11 millimeters. So Tony was in bad shape. He was 62 years old with a body mass index of 30. He has type 2 diabetes, stage 1 hypertension, and his last HbA1c, which was 14 months ago, was 8.8, which is in the danger zone. So Tony went to see his physician, and his chief complaint with his physician was this lesion, this lesion on his foot. And we do know that neuropathy too, but neuropathy and problems with the feet is a major complication of diabetes. So here, you start to see the beginning of this for Tony. So he went to his physician. What if the physician had taken the stand that this is not a big deal? You're going to be just fine. Go home. You're good. And the truth is, I would be hard pressed to find a physician or that would say, yeah, this is a big. I mean, I don't know any physician that would deny that this needed to be treated because he is such a poorly controlled diabetic, right? So at any rate, that's what we need to start. That's the way we need to start thinking and incorporating this into what we do. So it is a big deal. Infections are a very big deal in people who have diabetes. So Tony's case, if we run it through the classification system, the new one for periodontitis, we come up with generalized periodontitis, stage 3, grade C, which is a very rapid rate of disease progression. And this grade is actually modified. And the grade modifiers are HbA1c of 8.8 because it's so poorly controlled. And he's also obese. And we also know, because we know that obesity does increase the risk for periodontal disease progression. And so these are grade modifiers, and we need to be serious about taking these into consideration because it will dictate, it absolutely will dictate how we treat in the future and how we maintain this person after initial treatment. So bear with me for a second on this. So there's the old way of doing things and what I consider the new way of doing things in terms of diagnosis, treatment, and long-term stabilization of periodontitis, okay? So the way we used to do this, and I'm talking about with the previous classification system up until recently, and many practices are still doing this. It's a kind of a treatment was based on a one-size-fits-all cookie cutter approach that didn't really require us to think particularly critically about any of this. Okay, so we weren't taking into consideration things like diabetes, especially poorly controlled diabetes, right? So today we know so much more about this. We have to take those factors into consideration. Today we need to customize treatment according to what we know about periodontal disease and its relationship to overall health. So yes, more critical thinking is required. It doesn't mean it's harder. It just means we need to shift gears a little bit and start thinking a little bit broader, a little bit deeper, and understand the science better. So periodontal disease diagnosis, treatment, and long-term stabilization of the reduced periodontium. So that is, when we use that term, reduced periodontium, we're really talking about periodontium that has been compromised, it's lost bone and connective tissue after initial treatment. It's actually a new therapeutic target that was put into place by the 2017-18 guidelines. So what we have to do is focus on dynamic changes in the rate of disease progression. And that is often a function of systemic health, and we'll see that. So risk assessment for periodontal disease was a recommendation made by the American Academy of Periodontology as far back as 2008. And really what some of the researchers found is that, believe it or not, only 20% of the risk for periodontal disease is actually from plaque. It's actually 80%, the lion's share is actually from non-plaque related risk factors. And to your left, you'll see some of these other factors like smoking, poorly controlled diabetes, osteoporosis, immunodeficiency, rheumatoid arthritis, obesity, certain medications, most of them that dry up saliva, and genetics, which has a huge bearing on this. So these are factors, again, modifiers of the progression of disease here that we must take into consideration. So it's important for us to actually perform periodontal risk assessment. Now, these are systemic diseases that may be influenced by periodontal treatment. And again, this is a little bit different parameter. What we're seeing here is if we have a patient that needs to be treated for periodontitis, okay? If they have one of these diseases, it could, or conditions, it could be that not treating their periodontitis could complicate these diseases and conditions. And vice versa, treating it could improve some of these things. So, and again, here we are with this body of evidence that we are required now to really think about in terms of incorporating it into the diagnosis, treatment, and long-term stabilization of the periodontium. So when we talk about stabilizing the reduced periodontium, this was a new therapeutic target that was introduced with the new guidelines. And again, this has to do with the state of the periodontium, the connective tissue of it after a person has been treated. So think of it as after initial treatment, okay? So the bone isn't coming back unless there's a surgical procedure of some sort. So there is a reduced periodontium, right? And so it's about sustaining a reduced periodontium at this point. So the parameters that were defined in this, it was Lang and Barthold who did this. Remission was defined as when your symptoms become less severe, but they're not fully resolved. There's a significant decrease in inflammation, an improvement in clinical parameters, and modifying and predisposing factors are controlled, and disease progression it's stabilized. So what these researchers suggested is that low disease activity, that's key, low disease activity may be an acceptable alternative therapeutic target in long-standing disease. So again, it's about disease activity. And we know that in periodontitis, often, it's not a straight line in terms of progression of disease, that we have periods of quiescence and then activity. And so these are all considerations in the new guidelines. So looking at the assessment of the status and stability here, periodontal disease stability is defined as either no or minimal bleeding upon probing. Modifying factors. Modifying factors are things like diabetes, okay? And obesity and things like that. Okay, so these are, now we see modifying factors that are controlled. So it would be a patient, let's say, who has, let's say Tony, 8.8 HbA1c, and now he's lowered his HbA1c, let's just say by down to 7.2. It's better. Okay, it's much better. So it's maybe not fully controlled, but it's much better. Predisposing factors are more local things that like overhanging margins and other etiological factors that predispose to periodontal breakdown. And in remission and control, with bleeding upon probing, it's significantly reduced, but it's not eliminated, okay? There's still some there. Modifying factors are not fully controlled. And so it's all about getting these factors under control. And that is a new responsibility for us. And that really is about talking to patients about their diabetes and lifestyle modifications and adherence to physicians' recommendations on medications, and again, predisposing factors that are not controlled. So if we look at these two periodontal records here, we see Charlie has bleeding upon probing of 99%, almost every site in his mouth, and Bob, 15%. My question to you would be, who has the greatest risk for amplified systemic inflammation? And you know the answer to that. It's kind of obvious, right? So we need to start thinking through that, because we do know that there is egress of periodontal bacteria through the ulcerated epithelial lining of the periodontal pocket, and it's disseminated to the through the vasculature to targets all around the body that are distant from the mouth. Briefly, this concept of continuous risk assessment. So what I mean by that is assessing a patient's risk at virtually every visit, because things change systemically and locally in the mouth. So you see this axis here. These are modifiable risk factors. At the top here, it's risk factors that are controlled. On the bottom, they're uncontrolled. And then the horizontal axis is periodontal parameters improve. And on the left, it's actually the decline. And it goes from stable to remission to unstable. So here's an example. Let's just say we have a patient who presents with diabetes, and it's very well controlled. They have had treatment of periodontitis, and their periodontal parameters have improved. But the next time they come to visit, these periodontal parameters start to decline. You know, their HbA1c is still pretty good, but the periodontal parameters decline. And in the following visit, you know, we have further decline of periodontal parameters, and risk factors become uncontrolled. This is an unstable. So this is the same patient that went from stability of the periodontium to now instability of the periodontium. So these are the dynamic changes that need to be taken into consideration. Okay, point of care glycemic control testing in the dental practice. I'm sure our patients thought we were kind of weird when we started actually taking their blood pressure. Maybe sometimes still your patients think you're a little weird when you do that. But so the truth is they get it now. They've been indoctrinated into medical testing. And the research that I've seen on the acceptance of patients on glycemic control, chairside testing, suggests that they're all over it. They really like it. You know, just the realization that their oral health care provider, whether a dentist or dental hygienist, is looking beyond the tonsils and taking all this into consideration. The research I've seen suggests that patients are very, very happy about this. So this has to do with HbA1c and how it affects the risk for complications of diabetes. What you see here in this continuum are the classic complications of diabetes: retinopathy, neuropathy, peripheral artery disease, coronary heart disease, nephropathy, and periodontitis is considered by many to be the sixth complication because it's so predominant in patients with diabetes. The common denominator is that there's impaired host response that causes increased susceptibility to infection in tissues throughout the body. And so that's everywhere. And it's not just in the mouth, but it is in the mouth, right? And it's been suggested that a 1 percentage point decrease in HbA1c has an effect of decreasing by 35% risk for the microvascular complications of diabetes, and an average reduction of 0.2% in HbA1c comes out to about a 10% reduced risk in diabetes mortality. So this HbA1c is a little bit of a holy grail number that we need to become very familiar with. It has very big significance to us in dentistry. So what is it? It's the measurement of the amount of glucose that's actually attached to red blood cells, and it's correlated to the average blood glucose level over patients' recent history. So it's an average. It's a snapshot of about 3 months. So an HbA1c of 7 or less, we know, reduces the microvascular and neuropathic complications of diabetes. So again, the example we gave of Tony is decreasing, he's now all of a sudden managing his poorly controlled diabetes and getting it to 7%. That's a huge deal in a patient with diabetes. But here's the fact, though. Only about 37% of patients actually achieve this. So we've got our work cut out for us, right? So the guidelines tell us that we need to monitor HbA1c soon after the diagnosis of diabetes to reduce the macrovascular disease. For patients who are doing well and they have good glycemic control, they're stable, you can, the suggestion is HbA1c testing twice a year. And for those who are not doing well or meeting glycemic goals, testing every 3 months or 4 times a year. So it's exciting, very exciting, that a couple years ago, the American Dental Association, the other ADA, actually, approved a code for HbA1c testing in our office. Here are just a few of the devices that are used these are called point of care finger stick technologies. It's so again, it's a point of service testing. Yeah, and so the range that we want to see in patients are 6.4 or below. 6.5 or higher, that's when the red flags start to go up. And these are analyzers that actually, so what you do is do finger stick and get the blood with a pipette and then put it on analyzer to medium to analyze it. And let me go back here real quick. The CDT code for that is DO411, HbA1c in-office point of care, point of service testing. The other code, CDT 412, this is for blood glucose level test in office using a glucometer. And that was effective a year ago, 2 years ago. January 2019, and it provides immediate findings of a patient's blood glucose level at the time of sample collection. And many insurance plans are honoring this now. And so the acceptable range is between 80 and 180 milligrams per deciliter. And I bring this up, I know we're talking about HbA1c, but I'm also bringing this up because there's absolutely a place for this in practice. This is a glucometer you see. It's a very simple test. And if a patient with diabetes does not bring their glucometer with them and they're there for a long procedure, the recommendation is that you take a look at what their blood sugar levels are before you begin the procedures. And there's other reason to do this. And the way we perform a finger stick is select which finger you want to use, massage it a bit, clean and dry the site using a lancet, puncture the skin. Usually a 30 gauge lancet will suffice for most people, but for people who have thinner skin, it's 25 to 28, 32 to 33 for very, very thin skin. So you wipe away the first blood before collecting the sample without milking the finger, place the sample into the analyzing device and read. And this is for the PST, or PTS Diagnostics A1C now, which is a great product. Okay. So who are the candidates for HbA1c testing? It would be, in my opinion, this is just Casey Hine talking here. Anybody who has gingivitis or periodontitis, I think I want to know. And the reason I want to know is because it may change the trajectory of their gingivitis or periodontitis and their diabetes. So I really want to know. People who are overweight or obese, people who have sedentary lifestyles, a familial history of diabetes, people who have a poor response to treatment, or they have delayed wound healing, that should be big red flags. People with symptoms of diabetes, anybody that you're treating that's immunocompromised, you want to know about their glycemic control, right? And then people in these high risk ethnicities here. It's important to monitor HbA1c. Here are some of the reasons, and we're talking about not screening here. We're talking about monitoring their HbA1c. So you ask a patient, when is the last time you had HbA1c testing? And they say, oh, it was 2 months ago. And you say, great, can I get a copy of those test results? Or it could be the patient who says, you know what, it's been 9 months, maybe even a year. And that's when you say, you know what, we can do that right here. And so here are some of these patients, the patients who have diabetes, how significant it is to monitor their HbA1c. So patients with a history of well-controlled diabetes, they have increased blood sugar levels, however, that may signal an increased risk for periodontal deterioration. So again, here's an example, and that is a history of well-controlled diabetes. And all of a sudden there's a spike in their blood sugar levels, and this could be signal increased risk for periodontal deterioration. So that's patients with no history of periodontitis, patients in periodontal maintenance, new patients, patients with prediabetes. And also HbA1c results may guide your periodontal treatment plans. And, adding things like adjunctive therapies, like hydrogen peroxide trays, site-specific antimicrobials, host modulatory therapy, and things, maybe holding off on cosmetic dentistry or complex cases until HbA1c, glycemic control improves. And this information also helps us define recare intervals. What do we do with positive test results? Well, first of all, we have an obligation to inform the patient. I strongly recommend following through with the physician for them to make a definitive diagnosis. That's not up to us. It's out of scope. Make sure we get a patient release of record, document referrals and track them. And then we have to ask ourselves, how do these results influence the current and future treatment plans? Does insurance provide coverage for additional prophylaxis? Many of them do for patients with diabetes. And here's reasons that we need to start thinking about in terms of reaching out to the medical community when you're unable to attain complete or accurate information about the patient with diabetes. How can you work together to co-manage this case? And if it's a patient who has not had a medical evaluation within 2 years, or a patient who presents with signs and symptoms of cardiovascular disease or other complications of diabetes, you need to reach out. If you know that you're going to be doing a procedure that is going to involve postoperative discomfort that may limit that patient's dietary intake, that's a consideration for contacting their physician. Frequent hypoglycemic episodes, the need for prophylactic antibiotics, and any kind of poor wound healing that's associated with the dental procedures. So again, we're talking about the long-term stabilization of the reduced periodontium. And we have a lot of patients who have diabetes, who are in periodontal maintenance, and many who need periodontal treatment, but the one thing that we know for a fact is the number one goal is to prevent or minimize the recurrence and progression of periodontal disease in these patients. And that means creating the ecological conditions that make survival for periodontal pathogens unsustainable. And this is really important. An important point here is that in diabetes and health, let's just say these two individuals we know for a fact, a person with health and a person with diabetes, when exposed to the same quantity and quality of bacteria, it's really not a level playing field. We know that in health, there is a lower inflammatory response. And in patients who have diabetes, there is this monocytic hyper secretory trait that makes them a hyper responder. So a little bit of bacteria in this patient with diabetes in their mouth is like wildfire. And I say this because it's so very important for us to empower our patients to make sure that they clean their mouths well. Okay. Plaque is a big part of this, right? It may not be the whole picture. Again, there's modifiers and systemic risk factors that we must take into consideration, but it starts with bacteria. So for patients with diabetes, it's even more important for them to have a clean mouth because they have a disproportionate, overexuberant response to bacteria. And I will mention this. Sunstar has lots of products that are truly wonderful, and it's a great company. They've done a lot of research in this area on diabetes, and actually just some recent research that was about diabetes and screening for diabetes using a Finnish a screening tool that was very effective. So they're all in on this and on diabetes. That's a big deal for them. That said, one of my favorite products, I think that they do have the market covered when it comes to interdental cleaning. And I highly recommend, I use these myself, actually, these interdental cleaners. They're excellent. And I think it's important for you to take a look at those. Also, there's some resources that you could download on my website that are actually patient education tools that there's a whole bunch of them. These are all free: adolescent obesity and periodontal disease, adult obesity and periodontal disease, diabetes and periodontal disease, et cetera, et cetera. There's one on cardiovascular disease, and you can brand these with your own logos. And again, there's actually, these are also on my website. These are animated mini messages that actually you can download, put on a tablet, let your patient actually listen to it. Great animations that you can use to passively educate them about periodontal systemic links. So there's been a ton of information here. And lots to think about. I'm going to recommend some starting points tonight. It can truly be overwhelming. So let's talk about the challenge to implementation and just making some baby steps here, some starting points. So my first suggestion is to start to screen your patients in your catchment area. Again, these are people, and you can do it low tech. You can use it just by asking your patients these questions from the American Diabetes Association, right? And so I highly recommend start screening patients for diabetes. Incorporate periodontal systemic risk assessment into everyday patient care. It's really, really important to start performing risk assessment, periodontal risk assessment. And there's a lot of great tools for that. And if you're interested, I have one that you could use. Just let me know. Start to implement the 2017-18 classification system. Pay particular attention to periodontal systemic risk factors such as glycemic control. And make it easy for patients with diabetes to maintain good oral hygiene. You know, you may want to give up on the floss. If it's a patient who won't floss, doesn't want to, make it easy. Suggest interdental picks. Sorry. Ask your patients when they were last tested for HbA1c. Correlate that information with their oral health status. And make a point to learn more about point of care testing for glycemic control. And most of all, stay the course. Let me know how you do. And this is my email address, my email address, that's my website. My email address is casey@caseyhine.com. I'd love to hear from you, and I'd love to help in any way I can. So please let me know. And thank you so much. And again, I want to thank Sunstar America for their support of this program and Viva Learning for hosting this tonight. And I will take questions. Okay, I got a question here. Are you aware of any studies that talk about the level of A1C in which oral cavity symptoms can be expected? I do not. Okay. Are you aware of any studies that talk about the level of A1C in which oral cavity symptoms can be expected? I am sorry, I am not aware of that. One other question, there's lots of them here, but answer live, here we go. In your experience or what you've seen, if you meet a patient with an unfavorable A1C, uncontrolled diabetes, is it beneficial, ethical, and good practice to put the patient on metronidazole or another antibiotic course outright? I would strongly suggest that not happen. Yeah, for many, many reasons. And another question here. Let's see if I can do one more. Many patients don't want any type of blood sugar testing because of life or health insurance concerns. Yeah, many patients don't want any type of blood sugar testing because of life or health insurance concerns. I understand that. Thank you, Joseph, for your compliment. Let's see. Thank you, Paige. Yes, I want to thank you so very much, everybody. And I want to wish you guys happy holidays. And I hope this will be a great new year. And may God bless you. Good night.